Hi, class. So, this week we're going to be talking about hematological disorders. Unlike many other body systems, the hematological system functions throughout the entire body. So, keep this in mind as we discuss the pathophysiology and assessment sections of the presentation. So, these are some of the learning objectives. We're going to look at the health history and some diagnostics. We're also going to look at specific blood disorders and the etiology and pathophysiology, as well as applying the nursing framework to these disorders. So, let's talk a little bit about the structure and function. There is a video here that you can watch on your own, and then we'll have a brief overview. So, once again, this is going to be brief because I'm relying on your foundational knowledge that you bring from anatomy and physiology. Back. Okay. A foundational understanding of the blood cells and bone marrow function is essential for comprehending most of the hematological disorders and alterations that we're going to discuss today. The bone marrow is the primary site for blood formation and maturation. Plasma, um, first blood cells, are throughout the body, and they're through a process of hematopoiesis. Blood cells are formed, developed, and differentiate into red blood cells, white blood cells, and platelets. Plasma is clear yellow, protein rich, that serves as a transport vehicle for materials carried in the blood, and the spleen stores, filters, forms, and defends blood cells. So, hematopoiesis is when most blood cells have a short lifespan. The body must continuously produce new ones through a process called hematopoiesis. The bone marrow is the primary site of hematopoiesis. However, during embryonic development or under certain conditions, the liver and spleen may also take part in this process. So, erythropoiesis is the production of red blood cells. It begins when erythropoietin, a hormone from the kidneys, stimulates the differentiation of the myeloid stem cells from into erythroblast. And low oxygen levels, such as in anemia or at high altitudes, trigger increased erythropoietin, prompting the bone marrow to produce more erythrocytes. This process takes about 1 week and requires adequate iron, vitamin B12, folate, vitamin B6, protein, and other nutrients. A deficiency in any of these can reduce red blood cell production and lead to anemia. And we'll talk about that further because we're going to talk about B12, folate, anemia. So, red blood cells live about 120 days and are mostly made up of hemoglobin, an iron containing protein that carries oxygen between the lungs and tissues. Mature red blood cells lack a nucleus and have limited enzymes. When the body needs more red blood cells, such as after blood loss, the bone marrow releases slightly immature cells called reticulocytes into circulation. Leukocytes, white blood cells, protect the body from infection and foreign substances. They are classified into granulocytes and lymphocytes. The main role of lymphocytes is to recognize and destroy foreign material. Platelets or thrombocytes are cell fragments derived from megakaryocytes in the bone marrow. They help control bleeding and while circulating in an active state, support and maintain blood vessel integrity. So, plasma is a liquid portion of the blood after cells are removed. It's composed of about over 90% water plus proteins, clotting factors like fibrinogen, and nutrients, enzymes, waste, and gases. When blood clots, the remaining fluid is serum, which lacks fibrinogen and some clotting factors. Plasma proteins include albumin and globulin. Um, And albumin is made by the liver and maintains vascular fluid balance by creating osmotic pressure and can transport substances such as medications, bilirubin, and hormones. Low albumin, as seen in liver dysfunction, can reduce osmotic pressure and cause edema. So the blood has several functions. One is to protect it. The blood defends the body against infection and foreign substances through white blood cells, antibodies, and clotting mechanisms that prevent excessive bleeding. It also helps in circulation. Blood transports oxygen, nutrients, hormones, and waste products to and from tissues, ensuring cells receive what they need for metabolism and survival. It also maintains hemostasis by regulating fluid balance, pH, and electrolyte levels, and by distributing heat to support a stable blood temperature. So it also the blood regulates physiological processes such as blood pressure, temperature, and immune responses, and it ensures proper delivery of hormones and other signals molecules throughout the body. So hemoglobin consists of four subunits, each with a heme. Heme means that it's containing iron and it's attached to a globulin chain. Heme binds oxygen loosely and reversibly in the lungs. Hemoglobin binds oxygen to form oxyhemoglobin, giving arterial blood its bright red color. Oxygen is released in the tissues for cellular metabolism. In venous blood, hemoglobin binds hydrogen ions, helping buffer acid. Normal blood contains about 15 grams hemoglobin per 100 mLs. The RES, reticuloendothelial system, consists of tissue macrophages. Monocytes circulate for about 24 hours before entering tissues, where they become microphages that can live for months or years. Macrophages remove old or damaged cells, stimulate inflammation, and present antigens to the immune system. They also give rise to histocytes, phagocytic cells in the connective tissue. So, hematostasis occurs when a blood vessel is injured. In primary hematostasis, platelets stick to exposed collagen, release factors, and form an unstable platelet plug. In secondary hematostasis, clotting pathways, both intrinsic or extrinsic, activate clotting factors, converting prothrombin to thrombin. Thrombin then converts fibrinogen to fibrin, stabilizing the platelet plug and allowing vessel repair. So let's go down to assessment and diagnostics. So, a thorough health history and physical assessment provides key information for the hematological evaluation. Consider ethnicity and family history, as some disorders are some more common in certain groups. So when we look at sickle cell anemia, that is more common in individuals who have African descent. Assess nutrition, medications, and herbal supplements, since deficiencies or certain substances can contribute to hematological conditions. Note symptom onset, severity, and contributing factors, and evaluate their impact on function, distress, and coping. So, during your physical assessment, you should focus on the skin, oral cavity, lymph nodes, and spleen. Key hematological symptoms to assess include extreme fatigue, delayed clotting or abnormal bleeding, easy or deep bruising, and abdominal pain or joint pain. When doing a bone marrow biopsy or aspiration, that could possibly be as a result of thrombocytopenia, leukemias, anemias, or any primary or metastatic tumors. So it's usually performed at the posterior iliac crest with the patient prone or in lateral position. Patients may feel pressure during needle insertion and the brief pulling pain during marrow removal, and occasionally a scraping or a crunching sensation as the needle penetrates the bone. So the nurse wants to make sure to apply direct pressure for 5 to 10 minutes, cover site with sterile dressing. Of course, you want to keep an eye on that to make sure there's no excessive bleeding. The patient should rest for several hours, and you should always make sure you're monitoring for bleeding and infection. So, when performing spleen palpation, is best with the patient supine and the abdomen relaxed. Lightly palpate the upper left quadrant for tenderness. If there is enlargement in the spleen, palpate gently to avoid rupture. There is a video that you can watch where you can see this assessment done. The most common test under for routine screening of hematological function is the complete blood count CBC. The diagnostic test provides a highly informative profile of data on multiple blood values, identifying the total number of blood cells, leukocytes, erythrocytes, and platelets, as well as hemoglobin and hematocrit and red blood cells indices. So, a direct Combs test detects the presence of immunoglobulins, antibodies, on the surface of red blood cells that develop through sensitization to antigens such as Rh factor. This test is performed to diagnose hemolytic disease of the newborn, to investigate hemolytic transfusion reactions, and we'll talk about a little bit more about that later, and to aid in the differential diagnosis of hemolytic anemias. Clotting studies can assist with identifying deficiencies in clotting factors and um, vitamin K, and reveal that the patient is at a high risk for hemorrhage or clots. Bone marrow biopsy and aspiration, we already talked about that, but it is used to diagnose thrombocytopenia, leukemias, anemias, and primary metastatic tumors. So this really lists out all of the very common blood studies that are done. If you have a low red blood cell, that could mean that there's anemia, decreased oxygen carrying capacity. If you have a high red blood cell, that could mean polycythemia or risk for clotting. If you have a low white blood cell count, that's leukopenia, which is a risk for infection, may indicate bone marrow suppression. If you have a high white blood cell count, that usually means there's an infection, inflammation, or leukemia. Low platelets, which is thrombocytopenia, means there's increased bleeding risk. High platelets is increased clotting risk. So when you have abnormal clotting studies, PT, APT, or INR, there's a risk for bleeding or thrombosis, and may indicate clotting factor deficiencies. An elevated bilirubin means that there's hemolysis or liver dysfunction, and low albumin means there's poor nutrition or liver disease, or there's a fluid imbalance. So these are some other studies that we've already talked about. You want to make sure the bleeding time test is not recommended for patients with platelet counts under 75,000. So let's talk a little bit about transfusion. So, modern blood collection uses screening tests and volunteer donors, making transfusions relatively safe from disease like syphilis, hepatitis, and HIV. Whole blood transfusions are rare. Instead, only the needed blood components are given. One donation can be separated into red blood cells, plasma, platelets, granulocytes, clotting factors, or albumin. Packed red blood cells are usually used to treat anemia or significant blood loss, increasing oxygen carrying capacity. Plasma, fresh frozen plasma, is used to replace clotting factors in bleeding or clotting disorders. Platelets are used to treat thrombocytopenia or prevent bleeding in patients with low platelet counts. Granulocytes are used for patients with severe neutropenia and infections unresponsive to antibiotics. Clotting factors are used to treat specific clotting factor deficiencies, possibly hemophilia, but we won't talk directly about that today. And albumin is used to restore blood volume in shock, burns, or low albumin states, and maintains oncotic pressure. So, blood transfusion safety and administration. First, you want to make sure there's compatibility checks. Blood components are matched to the patient via ABO, RH. ABO incompatibility is a hemolytic reaction. RH negative patients must receive RH negative blood. Storage and handling blood is stored under strict conditions. Limited time is allowed outside of storage. So, for instance, when they send the blood up to you, you have to administer it within 30 minutes. If that doesn't happen, you want to make sure that gets sent back down to the blood bank. Nurses must follow institutional guidelines and policies for storage, infusion time, and administration documentation. Pre-transfusion requirements usually include obtaining informed consent and physician order, confirming IV access and supplies before releasing blood, two licensed staff, those are usually RNs or one RN and one LPN, verify patient identity, blood type, component type, volume, ABO, RH compatibility, and expiration. The patient assessment usually includes baseline vital signs and respiratory status. You want to make sure you explain the procedure, expected reactions, and when to report symptoms, providing emotional support as well as information on transfusion. The monitoring is usually takes place within the first 15 minutes. That's when there's high risk for reactions. You want to observe closely. You do not leave the room. And then you continue hourly assessments. But you also want to keep the patient's condition in mind. If your patient is a high risk for fluid volume overload or also is showing um, really low oxygen status, you may have to provide more frequent checks on your patient. So, blood transfusions require knowledge of potential reactions and facility policies in response to those reactions. Nurses play a key role in providing evidence based care to reduce reactions. Delayed hemolytic reactions may occur up to 14 days post transfusion, so you want to keep that in mind. One of the most common reactions is febrile non hemolytic reaction. This is when the antibody reaction to granulocytes or platelets in infused blood component. You usually see a temp increase of 1 Celsius or 2 Fahrenheit, chills, headaches, and chest pain. You will always want to stop the transfusion immediately, notify your provider, get vital signs, and the other one that we'll discuss is the acute hemolytic reaction, which is caused by an infusion of ABO incompatibility blood. And it's the most dangerous. With this one, you'll see fever, chills, hypotension, flank pain, low back pain, jaundice, hemolysis, which is vascular collapse. You, of course, want to stop the and immediately stop the transfusion, get vital signs, notify the provider. Okay. So your nursing reactions, if you suspect a reaction, is to stop the transfusion immediately. Do not flush because you'll be flushing that blood in there. You want to contact the provider, get orders, labs, urine, and then you want to assess vital signs, level of consciousness, lung sounds, pain, and this is ongoing. You're going to collect those labs. You're going to also send the blood down in the blood bag to the lab. Um, you want to also document. And that's, of course, the last thing you're going to be doing. You're probably going to be in the room with your patient while this is going on. So let's look at some non malignant hematological disorders. We'll look at malignant hematological disorders next semester. So there are several types of anemias. They're classified by decreased red blood cell count production, which is hypoproliferation, increased red blood cell destruction, which is hemolysis, or blood loss. And causes can be determined by bone marrow response or immature red blood cell proliferation and maturation. The hyperproliferative anemia occurs when the marrow produces too few red blood cells, shown by a low or inappropriately normal reticulocyte count. And causes may include bone marrow damage, deficiency of erythropoietin, so that might be a problem in the kidneys, or nutrient deficiencies in the form of iron, B12, or folate. So, factors affecting anemia symptoms include severity, rate of onset, whether it's acute or chronic, metabolic demands, coexisting conditions. So, for instance, if your patient has heart failure or other pulmonary diseases that would exacerbate the anemia. So, rapid anemia is more severe symptoms, can cause vascular collapse with acute hemoglobin losses. Gradual anemia may cause mild fatigue or slight tachycardia. Healthy patients may tolerate large reductions without major symptom changes. Activity levels and comorbidities influence symptom severity. Hypothyroid or sedentary patients may be asymptomatic. Patients with heart, vascular, or lung diseases may have pronounced symptoms at a higher hemoglobin levels. Some anemias, as in sickle cell disease or autoimmune disease, have additional symptoms inherent to that disease. So, some of the complications of severe anemia include heart failure, angina, um, delirium. Patients with heart disease are at higher risk, and specific complications will vary based on anemia type. So, anemia evaluation usually includes initial labs like the CBC, so hemoglobin, hematocrit, reticulocyte count. Additional tests may include iron studies and B12 folate studies. CBC review helps identify and isolate anemia versus other hematological disorders like leukemia. Bone marrow aspiration would assess cellular abnormalities, and GI studies like uh, colonoscopy or endoscopy may detect ulcers, polyps, or tumors at potential sources of blood loss. Anemia management focuses on treating the underlying cause. In severe cases, loss or destroyed red blood cells may be replaced with packed red blood cells. Specific management strategies for each type of anemia we'll discuss. So, anemia assessment includes health history and physical exam to identify type, severity, and impact on the patient. Common symptoms include weakness, fatigue, malaise, pallor of skin, and mucous membranes. So it also may include jaundice, angular colitis, brittle, rigid nails. The tongue may be sore and beefy red. And iron deficient anemias, you may have a smooth red tongue, restless leg syndrome. Medication, you want to make sure you look at their medications because some drugs can suppress bone marrow. They may cause hemolysis, lysis, interfere with folate, or induce GI bleeding. So, older adults with anemia often experience fatigue, dyspnea, and confusion due to the reduced cardiac reserve. Those with pre existing renal or cardiac diseases or recent surgery are at higher risk for morbidity and mortality. So, these are some common medications that might interfere with platelet production or function, interfere with coagulation factors, or decrease vitamin K levels. So, we're going to be aware of those. Complications of anemia include heart failure, chronic low blood volume forces the heart to increase output, and you want to assess for heart failure signs. Neurological complications, you may have numbness, loss of position, vibration sense, balance and gait problems, and mental status changes. So you may see confusion or delirium. The major goals for the patient with anemia include decreased fatigue, attainment or maintenance of adequate nutrition, attainment or maintenance of adequate tissue perfusion, effective management of prescribed treatment plan, and absence of complications. Nursing interventions in general for anemia include making sure there's balanced activity, exercise, and rest, ensuring adequate nutrition, maintaining perfusion, providing education on medications and nutrition, and monitoring vital signs and oxygen saturation in particular, as well as giving supplemental oxygen as needed and watching out for complications. So now we're going to get into more specific anemias. We'll start with iron deficiency anemia. The epidemiology on that is it is the most common nutritional deficiency worldwide. The pathophysiology is it starts with low iron, which leads to insufficient hemoglobin and leads to reduced oxygen delivery. Iron also is needed for ATP production, so that impacts glucose metabolism and DNA synthesis. Iron is stored in the ferritin in the liver and is transported by transferritin. So, some of the risk factors are dietary insufficiencies, blood loss, lead exposure, and also pica, which is craving non food items. Often you'll see this in children or pregnant women. So, you may talk about that in your maternal child. Some manifestations include fatigue, pallor, tachycardia, tachypnea, and shortness of breath. The mucous membranes changes, so we'll talk about glossitis, and the nails may be spoon shaped and soft. Severe or chronic, you may see cognitive impairment and developmental issues in children. So, diagnosis is done through the CBC, so you'll see low hemoglobin and hematocrit. Serum ferritin would be low. Other labs may include serum iron, and you want to also assess for blood loss. So you might see some GI studies in this one to see if there is a GI bleed. Um, Also, if someone has chronic or long menstruation cycle, you want to that could also be a cause. Treatment includes dietary iron, red meat, leafy greens, beans, iron fortified cereals, vitamin C, iron supplements in the form of oral or perinatal iron. So you want to minimize blood loss, so control for hemorrhage or give hormonal therapy for heavy menses. Patient education would include taking supplements daily as prescribed, reporting bleeding, fatigue, or dyspnea, lead exposure avoidance, and prenatal teaching. Assessment focus should be on vitals, tachycardia, and tachypnea in particular, fatigue, pallor, shortness of breath, neurological changes in terms of change in the level of consciousness, also labs, hemoglobin, ferritin, and iron studies, and blood loss history. Now we're going to get into aplastic anemia. This is very rare. There's 2 to 4 cases per million in the US. The pathophysiology is bone marrow damage that could be caused by chemicals, medications, or autoimmune. And then you'll have a decrease in red blood cells, white blood cells, platelets. And that would be pancytopenia, but the cellular immune response produces cytokines that suppress stem cell growth. The manifestations include red blood cell deficiency, you'll have fatigue, pallor, tachycardia, tachypnea, dizziness, headache. White blood cell deficiency would be threaded infections, prolonged recurrent infections, and platelet deficiency. So diagnosis is done, of course, through the CBC. So you'll see low RBC, white blood cell count, and platelets. Coagulation test, you want to evaluate the bleeding risk. Hemoglobin is being looked at, and you may need to have a bone marrow biopsy on this patient and look at iron levels. Treatments done through blood transfusion, RBCs, and platelets, and this is for the symptomatic person. Bone marrow transplant may be needed, and medications in the form of epogen, immunosuppressive therapy, and assessment includes vital signs, CBC bone marrow, oxygen saturation, bleeding signs, looking for fatigue and pallor. Nursing interventions include providing supplemental oxygen, administering blood products, implementing bleeding precautions, and protecting for injury. Teaching is avoiding infection exposure in crowds, sick, context, making sure that they get their flu and pneumonia vaccine, reporting fevers, avoiding trauma or injury, educating on early signs of anemia, infection, and bleeding, and maintaining adequate nutrition. So, folate, vitamin B9, deficiency anemia, the pathophysiology is folate B12, essential for DNA synthesis, is low. And that impacts RBC maturation, heme formation. The folate deficiency is impaired erythrocyte maturation, which leads to the anemia. The severe deficiency in pregnancy can also result in folate. So, this is usually something, folate supplements is usually something that is pretty standard in the patient who is pregnant. Risk factors include poor dietary intake, malabsorption, and that happens in Crohn's disease. We'll talk about that when we get to GI surgery. So this could also happen if there's a gastric bypass surgery, medications, metformin, anticonvulsants, oral contraceptives, and hemodialysis also could put the patient at risk for this. So manifestations are pallor, fatigue, tachycardia, tachypnea, dizziness, bleeding risk. Neurological include um, usually sometimes confusion. Um, Specifically, if you have this in pregnancy or infants, you may see developmental delays. Diagnosis is done once again through the complete blood count. So you're going to see low hemoglobin, serum folate. Treatment includes diet, leafy greens, legumes, fortified cereals, nuts, yeast extracts, supplements in the form of folic acid orally. And you want to differentiate between B12 deficiency. So, folic acid corrects anemia but does not prevent B12 related neurological damage. So that's really important. Assessment focus, you want to focus on the vitals, tachycardia, tachypnea, symptoms like fatigue, pallor, shortness of breath, labs like hemoglobin and folate. Teaching includes diet, making sure that the patient is getting sufficient dietary sources of folate. Prenatally, they have to increase their amount. And this is essential to prevent neural tube defects in the child. You want to make sure they can report symptoms of fatigue, shortness of breath, dizziness, confusion, and supplemental education, especially for those patients who have GI gastric bypass surgeries, and educating them on certain medications that might interfere with folate absorption. So let's look at vitamin B12 anemia. The pathophysiology is that dietary B12 comes from anemia proteins. So this intrinsic factor from the stomach binds to B12 and it is absorbed in the ileum, and that's in the um, the the small intestine tract. Deficiency results in impaired RBC maturation, and this results in anemia. The risk factors, especially in older adults, individuals who have GI disorders, Crohn's disease, or celiacs, autoimmune diseases like pernicious anemia or AIDS, alcoholism, malnutrition, long term vegans and vegetarians, and medications that reduce gastric acid like PPIs and H2 blockers. So, manifestations include, once again, fatigue, pallor, tachycardia, tachypnea. Neurological, you may have numbness, tingling, confusion, mood changes. Severe cases, you may also see peripheral neuropathy or cognitive impairments. Diagnosis is done through the CBC. Once again, hemoglobin and hematocrit are low. Serum B12 assay is also altered, and through history and physical symptoms, and also diet and absorption issues. So treatment includes B12 rich foods in meat, seafood, and eggs, supplements. So it may be oral B12. However, if it's severe, that might be an IM injection of B12. Vegans and vegetarians may have to just traditionally and typically take in oral supplements. That also may be the case for people who have Roux-en-Y gastric bypass disorders or they've had the surgery. You want to monitor folic acid use. You want to also avoid nitrous oxide anesthesia. And you want to provide supportive care, assessing for pain, mobility, and fall risk due to neuropathy. And this patient, you may want to consider PT and OT. Assessment focus should be on vital signs, looking for those symptoms, labs, safety, and GI function. So, atrophic glossitis is characterized by a loss or absence of filiform papillae on the tongue's dorsal surface, which makes the tongue surface appear red, beefy red, and shiny. This may indicate nutrient deficiencies, including B12, but it also could indicate folate acid and iron deficiencies. So, some common neurological manifestations with vitamin B12 deficiency, there included would be peripheral neuropathy, which is that numbness, tingling, burning in the hands and feet. Cognitive and psychological would include confusion, dementia, depression, and mood swings. Motor would include poor coordination and balance. Oral and visual would be glossitis, which we talked about, altered taste, stinging tongue, and visual disturbances. The Limette sign is a sudden electrical shock like sensation radiating down the spine or the limbs. The video there will show you can watch it, and it's triggered by neck flexion.
Lermite sign is
When you're going to watch it complete, you can watch it on your own.
sign is
Okay. So, when teaching the patient with B12 deficiency, you want to emphasize the need for vitamin B12 supplements because the lack of vitamin B12 in plants, vegans, especially, immediately report any clinical manifestations of fatigue, shortness of breath, numbness, and tingling. This is especially important with prenatal teaching. Pregnancy may increase the demand for vitamin B12, so they may need to have prophylactic oral supplements. Radiation for advanced cancers. This therapy may increase the need for vitamin B12 supplements. Actions of acid reducing medications may also cause the B12 deficiency. So they want to decrease the function of the parietal cells in the stomach, which produce intrinsic factor. So, pernicious anemia is caused by a lack of intrinsic factor. Although pernicious anemia is often erroneously, which inaccurately, used as a synonym for vitamin B12 deficiency, it actually is different. Pernicious anemia is an autoimmune disease that leads to a vitamin B12 deficiency because of the body's inability to absorb vitamin B12 without intrinsic factor. So usually for this to distinguish, there's a Schilling's test is done. This is a 24-hour urine test that indirectly measures intrinsic factor and is used to distinguish between pernicious anemia and malabsorption. So let's talk about sickle cell anemia. Out of all of the anemias that we've talked, this is probably the one that could lead to death. So we definitely want to know the signs for the early signs and symptoms, and we want to know if our patient comes in with this disorder. So the epidemiology around this is it's the most severe form of sickle cell disease. 2 million carriers and 72,000 people have this disease in the US. The pathophysiology is it is an autosomal recessive disorder caused by sickle hemoglobin gene. So we'll talk a little bit more about how that gene creates a malformation in the actual red blood cell. So we're going to talk a little bit more about the crises, but some of the manifestations would include fatigue, pallor. The biggest one for this is excruciating joint pain. So this pain erupts from swelling in the joints, bones, chest, and abdomen. So you're going to see possibly organ damage, delayed growth, fever, possibility with infection, and some clinical signs appear even after 6 months. So we need to watch that. Assessment includes vital signs. So you're going to see tachycardia, tachypnea, fatigue, pallor, pain, swelling. That's a big one. Jaundice, hand foot syndrome. We'll talk about that. Infectious signs, labs. Of course, we're going to see the low hemoglobin. And then there's psychosocial because someone with this chronic disease is going to have a problem with chronic pain. So they may have depression, anger, as well as guilt. Treatment includes oxygen therapy, which reduces hypoxia, aggressive hydration. This is important. This is increases the blood volume and helps the blood to move because of that sickle formation of the red blood cells. So it prevents renal complications as well. Pain management is big with this, usually opiates, alternatively complementary options as well. Blood transfusions improve oxygen delivery, antipyretics to manage the fever, education, especially in crisis management, family support, and psychosocial care. Long term for these patients is going to definitely be there's going to be a lot of education and a lot of monitoring from their primary provider. So, sickle cell trait is both parents must carry the gene for a child to have sickle cell disease. However, carriers, parents, 25% chance of the child having sickle cell disease. So if you have one parent that's a carrier, that child could possibly have sickle cell. And the inherited sickle cell trait from one parent plus the normal gene, that may lead to a carrier. But this patient is usually asymptomatic. So in a normal red blood cell, the red blood cell is round. They have a biconcave shape and it's flexible. In sickle cell disease, the red blood cell becomes rigid, it's sickle shaped, and can stick to the vessel walls. So there's reduced blood flow. Severe blockage can lead to tissue ischemia and infarction, pain, swelling, fever. Early oxygenation can reverse sickling before rigidity sets in. Emphasis on these patients often need supplemental oxygen. Crises are intermittent and can be triggered by cold, also increased stress. So, chronic skin ulcers or sickle cells are caused by repeated vaso-occlusion, block of small blood vessels by sickled red blood cells. This leads to poor blood flow and tissue ischemia, especially in areas with limited circulation like the lower legs and ankles. Characteristics include painful, slow to heal, and recurrent sores. They may appear as shallow, irregular wounds with surrounding hyperpigmentation, and they're common in adults with long-standing sickle cell disease and a history of multiple crises. A potential complication of anemia is heart failure. The reason is chronic low hemoglobin reduces oxygen delivery to tissues, this causing the heart to work harder, which increases the cardiac output to compensate. Over time, this extra work can lead to ventricular hypertrophy, cardiac dilation, and eventually heart failure. Some other complications include tingling, numbness, delirium or cognitive impairment, fatigue, and decreased functional capacity and organ damage. So let's talk a little bit about going back to just overall sickle cell is the most common form of sickle cell crisis is vaso-occlusive crisis. This results from accumulation of erythrocytes and leukocytes in the microcirculation, restricting blood flow to the tissues and causes hypoxia, inflammation, and necrosis. A plastic crisis results from infection with the hemoglobin levels fall rapidly and the marrow cannot compensate, which is evidenced by absence of reticulocytes. And then you have the sequestration crisis, which results when sickle cells are pooled in the organs. In young children, the most common site of sequestration is the spleen. In adults, the most common organ involved are the liver and the lungs. So, the infection related clinical manifestations make acute chest syndrome different from patients who experience pulmonary infarction due to coronary artery disease. In adults, chest pain may be from infection, pulmonary infarction, or pulmonary fat emboli and has a higher mortality rate. Early diagnosis, rapid assessment, and intervention are related to improved mobility, and mortality. Acute chest syndrome is managed by prompt treatment with antibiotics. Incentive spirometry has been shown to also significantly reduce the incidence of pulmonary complications. In severe cases, bronchoscopy may also be needed, and also corticosteroids may also be helpful. Transfusions can reduce hypoxia, and pulmonary function should be monitored carefully to detect symptoms of pulmonary hypertension. Okay, so sickle cell disease teaching, you want to make sure that the disease is understood, explain the the unpredictable course, and the importance of early intervention during crisis to reduce duration and complications. Infection prevention, including maintaining updated vaccine, flu, and pneumococcal, practicing good dental hygiene, monitoring cuts, sores, and insect bites. And in terms of daily life, you want to make sure they're maintaining normal activities within limits, encouraging rest, and making sure that they follow their therapeutic routine. Pregnancy is risk, higher chance of crisis during pregnancy. Maternal infant complications include low birth weight, preterm labor, hypertension, miscarriage, and stillbirth. So there should be increased monitoring for the pregnant person. Genetic counseling is also greatly encouraged for a patient who is a carrier that is planning on having children. So let's talk about bleeding disorders. Definition is a failure of normal hemostasis can cause mild to severe bleeding and sometimes spontaneously. Causes include platelet related, low platelet count, or dysfunctional platelets, coagulation factor related, inherited or acquired factors, vascular deficits in the form of structural vessel abnormalities. The patterns usually are platelet or factor deficits or defects, bleeding anywhere, vascular deficits, and usually localized. Some patients may have multiple defects. So, some bleeding precautions for the patient who has thrombocytopenia or other bleeding disorders include preventing trauma, using soft toothbrushes, avoiding flossing if platelets are very low, and padding bed rails and avoiding contact sports. Minimizing invasive procedures, using small gauge needles, applying firm pressure after injections or venipuncture. Monitoring for bleeding, checking gums, nose, urine, stool, and skin for bruising or petechiae. Avoiding medications that increase bleeding, which can include NSAIDs, aspirin, and certain herbal supplements. Safety measures, avoiding sharp objects, fall precautions, and using assistive devices when needed. Educating the patient and family to report any unusual bleeding, bruising, or persistent nosebleeds immediately. So when we look at thrombocytopenia, the epidemiology is at 3.8 million in the US affected. So pathophysiology is often post-viral or post-immunization in children. In adults, they may have an autoimmune or medication induced. Um, so hemophilia means that there's that factor 8 or factor 9 deficiency. There's impaired clotting, spontaneous bleeding. And DIC, we're going to talk more specifically about that. Risk factors include malignancy, infection, and medications, especially sulfa drugs, and autoimmune conditions, including lupus. and we'll talk about DIC. Manifestations include easy bruising, petechiae, mucosal bleeding, and in severe cases, you'll have bleeding in vital organs, including the brain and liver. Diagnosis is done through the CBC, looking at the platelet counts, and it's usually under 150,000. Bone marrow biopsy, coagulation studies, including PT, APTT, fibrinogen. Treatment includes glucocorticoid steroids, um, IV factor replacement. You want to, in DIC, we'll talk about that, but you're going to treat the underlying factor. Assessment is platelet counts. You want to look for ecchymosis, petechiae. Interventions are bleeding precautions, avoiding trauma, making sure that you're not giving unnecessary IM injections, and also possibly contraindicated rectal procedures. You want to provide direct pressure to any wound or if there's any bleeding. Safe environment, clutter free, minimizing blood draws. Patient education should include educating them on bleeding precautions, also avoiding sexual intercourse if their platelets are under 50,000, and the importance of frequent CBC and lab monitoring. So when we look at polycythemia vera, the epidemiology is 5 per 1 million. So usually in adults over 50 years, and it is rare in on individuals that are under 20. The pathophysiology is overproduction of red blood cells, which leads to hyperviscosity and slowed circulation. So the hematocrit is usually over 48% in women and over 52% in men. And the hemoglobin is usually over 16.5% in women and over 18.5 in men. So this hyperviscosity increases risk for thrombosis, organ congestion, and hypoxia. Manifestations usually are fatigue, headache, dizziness. So you may have an enlarged spleen. You'll also possibly have pruritus, facial flushing, visual disturbances, possibly nose bleeding, and bleeding on the gums. Diagnosis is done through CBC, increased RBC. White blood cell also may be increased. Bone marrow biopsy would show increased RBCs. Treatment is usually therapeutic phlebotomy, which removes 350 to 500 mLs weekly until the hematocrit is at a normal level. Chemotherapy also in or interferon could suppress the marrow. Radiation, it's rarely to suppress marrow. It's rarely used, but it could be used in severe cases. Antiplatelet therapy, low dose aspirin. So, assessment, monitoring for dyspnea, dizziness, headache. Vital signs are checked frequently. You want to watch for hypotension and tachycardia. Interventions are routine CBCs. This patient may need the phlebotomy and chemotherapy monitoring, increasing fluid intake to reduce hyperviscosity, ensuring rest to reduce cardiac workload, elevating legs to improve circulation and reduce the chance of getting a DVT, and addressing cardiovascular risk factors, including obesity, hypertension, diabetes, smoking, and avoiding restrictive clothing. So, neutropenia is defined usually as a neutrophil count of under 2,000. It's caused by decreased production or increased destruction of neutrophils. Neutrophils are essential for preventing bacterial infections. Infection risk, increased risk for external, so infections in the GI tract or in the skin. Risk depends on severity and duration of neutropenia. So this would be, we would worry about this in our patients who had cancer. So we'll talk a lot about that next semester. Other risk factors included duration of neutropenia, and underlying chemo, um, or possibly other medications that could cause neutropenia. So, lymphopenia is defined as a lymphocyte count under 1,500. Causes and usually cause medication, long-term corticosteroids, radiation, medical conditions, infectious or viral infections, HIV, um, neoplasms, including breast cancer, advanced Hodgkin's disease, lifestyle, including excessive or prolonged alcohol use, and clinical significance. Usually in mild lymphopenia, you'll have an asymptomatic patient. In severe lymphopenia, you'll have decreased B cells, which will increase bacterial infections. And with decreased T cells, you'll have opportunist infections. So, with DIC, disseminated intravascular coagulation, this is a life threatening systemic disorder with simultaneous microvascular clotting and bleeding both at the same time. So, some of the causes and triggers are sepsis, trauma, cancer, shock, allergic reactions, and most commonly infection or malignancy. So the pathophysiology is usually there's an underlying disease trigger that leads to widespread inflammation, and that activates coagulation. The normal anticoagulation pathway fails, and then this leads to this initial clotting, then depletion of platelets and clotting factors, which leads to bleeding. So, some clinical significance is you have severity varies, but this can come on rapidly and be very life threatening. So, with DIC, some of the signs and symptoms are they include you have low platelets, and you also have increased PT and APTT thrombin time. So you'll have petechiae, tachycardia, pain, hypoxia, hematuria, confusion, and anxiety. So you have both increased bleeding and also with the clotting factors. And then you also have a need for blood. So this can result from severe trauma. So this is just an acronym that you can use, bloody mess. So severe trauma in a patient may result in the development of DIC in a complex sequence initiated by the injury. All platelets and clotting factors form multiple thrombi throughout the body, secondary to alteration of the body's normal anticoagulant mechanisms. When all of the body's stores of platelets and clotting factors are exhausted, spontaneous bleeding occurs from nearly every orifice because there are insufficient circulating platelets and clotting factors to stop the bleeding. The multiple emboli cause tissue necrosis, leading to multi system organ dysfunction. DIC is not a disease process, but occurs as a complication of another disorder or condition, usually trauma, blood transfusion reaction, postpartum hemorrhage. So, the most critical factor in managing DIC is treatment of the underlying cause. Until the cause is controlled, DIC will continue. Correcting the secondary effects of tissue ischemia by increasing tissue oxygenation, replacing fluids, correcting electrolyte abnormalities, and administering vasopressor medications is also important. When serious hemorrhage is present, depleted coagulation factors and platelets are replaced to promote normal hematostasis and reduce bleeding. The extent of hemorrhage and need for any invasive procedures are important considering in determining the decision to provide transfusion support. So, cryoprecipitate is given to replace fibrinogen and factor 5 and 7. So we'll talk a little bit more about that. Cryoprecipitate is used to maintain hematostasis because it provides clotting factors. Patients receiving cryoprecipitate are managed in the intensive care unit where they can be closely observed with hemodynamic monitoring equipment. Nurses care for patients at risk for DIC. Then you want to make sure that you're doing an assessment identifying high risk patients that are going through trauma, sepsis, or hemorrhage, monitoring for thrombosis and bleeding, tracking trends in the lab values, especially with platelets, fibrinogen, through PT, APT, T, and D dimers. You want to also be monitoring their more organs, kidneys, in particular, risk for ischemia, their liver, monitoring liver function test, watching for reduced albumin and clotting factor production, be looking at their lungs, monitoring for respiratory function, their CNS, watching for headache, visual changes, or altered consciousness. Interventions focus on preventing end organ damage and supporting perfusion while controlling bleeding and thrombosis. And there you have your references. So we're going to talk about this in class. I hope this video has been helpful. And if not, come and talk to me.